Is everybody about ready? We've got a lot to do in a short time. Oh, yeah. Oh, no, it's okay.
Yeah, well, they just did their resource management. That was really good. That came together pretty fast. And there was I think that we're waiting for funding. For funding. That's very good news. So maybe you can tell us more about that, and then moving forward, we can. Who's on that? Who's on the subcommittee or subcommittee? I need assistance. I need assistance to touch base with you.
Okay, is everybody ready to go? If so, I'd like to call together the stroke committee meeting. We're 15 minutes late already. To save time, I've done the roll. Not here is Ronnie Eichler, Paula Sarto, and Denise Williams, correct? Yes. All right. First up on our list is a discussion of the 83rd legislative session. And the guys will be very happy to know that $5 million was approved at that time in Senate Bill 1, and it's item 97 if you want to look at it. And basically it says out of the funds appropriated above in strategy A.3.1, chronic disease prevention, the Department of State Health Services may expend $2.5 million in general revenue funds in fiscal year 2014 and $2.5 million in general revenue funds in the fiscal year 2015 for the purpose of funding the Texas Council for Cardiovascular Disease and Stroke. The Texas Council for Cardiovascular Disease and Stroke shall allocate $4.5 million of those funds over the biennium to the Stroke System of Care Coordination, parentheses Lone Star Stroke, parentheses, and $500,000 of these funds over the biennium to the stroke/STEMI data collection. So this is great news because with money, actions happen. Now, in regards to what actions are going to happen, that's still being milled around at the Department of State Health Services and pushes me into item number 2, which is my report from the Texas Council of Cardiovascular Disease and Stroke. As a side, I'm now acting chair of that committee. And at that last meeting, what was decided is we were trying to more focus that council into a 3-pronged work in stroke prevention, acute stroke, and chronic disease. In regards to preventing stroke, the idea is to continue to partner with the Stroke Partnership. In regards to acute stroke, to partner with GTAC. In regards to chronic stroke, we formed a new subcommittee to try to work out a plan on how to best help people with chronic symptoms of stroke and heart disease. At the meeting, we also had some great epidemiology reports. basically focusing on Medicaid spending in our state for heart disease, stroke, congestive heart failure, hypertension. And I don't have a graph to show you, but I can tell you that it's parallel. That is, there's been no increase in the Medicaid funding per year in congestive failure, hypertension, ischemic heart disease. But in stroke, there's a clear trend of increasing expenditures in stroke disease. And so obviously from a state standpoint, expenditure standpoint, we need to try to decrease that. So those are the three things from the Texas Council of Cardiovascular Disease and Stroke. And that rolls us into data collection. And Johanna, do you have anything you want to say about that?
I just want to report that our work group has been essentially dormant because we're waiting for funding. So now that we may have the potential to create an IT infrastructure, I think that we'll reconvene and assign that work group to various members of the committee.
What I'm hoping the work group will do is review the data elements that you think would be most helpful, in that now there's cloud recording and stuff available as well. And then we'll work with all our partners to make sure that everyone works together on this. Next is EMS stroke education program recommendations, and Homer's been working on this.
Yes, sir. We had agreed to request some input from the Education Committee, and I think EMS and perhaps the medical directors. In contacting those folks, they've suggested we put it on the agenda for November, address it, and we'll get something from them then.
Great. And are you also doing some survey monkeys as well to the rats?
Yes, sir. I was trying. I got some of them kind of kicked back and ate up. We're working on that, but I think I've found my problem. You had that. We'll get it worked out and be back going again and requesting some, information from folks. Yes.
Well, one thing I think I would request that might go hand in hand with Dr. Grada's proposal and lecture he's about to give us is it might be interesting to survey them on the each rack specific bypass algorithm that they're using right now.
Okay, sure, we can do that.
Okay, trying to move along. Next, at last meeting, Healthcare Facilities Accreditation Program would like to be a company that reviews places and certifies them for the state, similar to the Joint Commission and DNV. We've sent to all the members and not discussed as a group, but individually have looked at those requirements that they've put forth, and I put that on the floor right now for first recommendations and thoughts of the committee. Anybody have plus, minus?
In reviewing them, what I found is that their guidelines and their are much more restrictive. They appear more to be like comparable to the comprehensive guidelines. Is what that's my observation of them.
Any more comments from the dais? Agreed. Okay, so what I'd like to do, are there any comments from the audience, any thoughts in regards to HFAP? Seeing none, I'd like to move that we approve HFAP as a stroke facility designation and certificate, well, as a certifying agency for the state. Is there a second? Second, Dr. Cravens. Discussion? Seeing none, those in favor? and none opposed, so unanimous. So we'll make this recommendation to the General Counsel that HFAP be approved as a certifying agency. Next up, and I've tried to get quickly done because I wanted to hear what Dr. Grotta had to say. Dr. Grotta has some very interesting ideas that he'd like to give us on other bypass protocols that we could use, and I'll yield the floor to you, sir.
Okay, thanks, Neil. Let me do this. Give me a second. Okay, so I'm Jim Grotta. I'm the chairman of neurology at UT Medical School in Houston. I've been involved in stroke in the state since 1979, when I first moved here a long time ago, before my hair was gray and when I still had some hair. And I guess most of the efforts throughout the state, including the formation of this committee, I've been involved in. And most recently, as you all are aware, with the development of comprehensive stroke center certification, the need has arisen throughout the country to try to figure out which patients should go to which hospital. And so I want to make a few comments and hopefully stimulate some discussion about that particular topic. So when we did the NINDS, we were one of the sites involved in the original studies of TPA funded by NINDS, and when that drug got, sorry?
Could you please use a microphone, because the people that are viewing through the stream won't be able to hear you. I apologize.
Is there one? Is there a portable one?
Do you want to stand there?
Okay.
I don't think any of them are portable.
I'll do whatever you think I should do.
Oh, that's pretty good. You'll be
Okay.
careful, but
Okay, that's fine.
you got it.
Is that working?
Yes.
Okay.
Good. Thank you.
I just want to not have my back to people. All right, so in 1995, when TPA, the first publication of the TPA data was published in December of 1995, and then the drug was approved in 1996, in collaboration with the fire department in Houston, we developed a system for getting patients to hospitals that already could take care of them. Now, there was still, at that point, of course, no primary stroke center certification, but in the city, HFD and we knew which hospitals were able to deliver TPA, and so right from the beginning, there was triage of patients to those hospitals. But it was very much time-based. It was entirely based on time. So the patients had to be exhibiting acute stroke symptoms, and they should then be transported to the highest level stroke center within a 15-minute transport window. So at that time, patients were sent to what we thought were stroke centers, but it had to be within 15 minutes. If it was more than a 15-minute delay, they had to go to the nearest hospital. Then, moving forward over the next few years, when primary stroke centers did become designated in the state and in the city, the criteria remained the same. In fact, right up until now, for the most part, triage criteria in Houston is time-based, that patients have to go to a stroke center as long as it doesn't result in more than a 15-minute delay. Now, these are data from Houston, but my guess is any large metropolitan area where there are multiple hospitals, it's the same. Each of these little segments represents another hospital, and I can tell you that the three biggest segments here are the three comprehensive stroke centers in the Texas Medical Center. But you can see that there's a whole host of stroke centers that are receiving patients, and 50%, in fact 57%, doesn't show up very well, are in this sort of turquoise half of the pie there, which are other hospitals. So still, the vast majority of stroke patients in the city, and this is as of 2010, are being taken care of outside of comprehensive stroke centers. And in fact, if you look at the percentage of our patients who are in red on this graph, this pointer isn't working very well, but In fact, I've got one in my briefcase. Give me a second. I think. Looks like my son took it. Okay, for his science presentation. All right, anyway, what you can see is that on the absolute number of patients is the blue bar from 2004 to 2010. You can see the absolute number of stroke patients delivered by EMS to the Memorial Hermann Emergency Department. Actually, the average per month has been going down progressively since there has been the development of primary stroke centers in the city. And the percentage of the stroke patients that we see that are delivered by EMS as opposed to being transferred in has also declined. Well, I mean, that's good and that's bad. That means that patients are being taken care of at many other hospitals in the metropolitan area, namely primary stroke centers. But it also means that the number of patients being delivered to our emergency department is by EMS is going down. Our volumes are going up, but the reason our volumes are going up is because there's a large number of patients who are first being seen at primary stroke centers and then being transferred down later for their care. Sometimes this is good and sometimes it's bad, and I guess the point I want to make is that this system, we need to bring some organization into this whole system of triage and not just let it happen because as hospitals proliferate. So in 2011, there were updated guidelines published by the American Heart Association that says that EMS should transport to the nearest stroke center that can provide appropriate care. Now, this was in anticipation of the approval of comprehensive stroke centers. So that meant that these stroke centers had to be certified by an independent organization and have performance measures, and it recognized the issue of primary stroke centers versus comprehensive stroke centers. The question is the nearest stroke center always the most appropriate for the patient? And most importantly is how is a paramedic in the field trying to decide what's the nearest stroke center that can provide appropriate care? And I would submit that for the paramedic in the ambulance who's got a patient in front of them, how is that paramedic supposed to decide, okay, I've got all these different stroke centers I could take this patient to. What's the appropriate place? Is it the nearest one, or should I go someplace else to a comprehensive stroke center? So why is it important for us to appropriately triage patients? And these are the reasons. And this is why some patients, it's important, should go to a comprehensive stroke center even if they're in the first few minutes after their stroke and perhaps bypass a primary stroke center. First of all, if there's a large artery occlusion, TPA does not work very well. Only about 20% of large artery clots are going to lyse completely within 2 hours with IV TPA. So if you have a middle cerebral artery occlusion, and we've done this by using angiographic techniques and transcranial Doppler, only 20% of those patients are you going to get the artery open with IV TPA. So we clearly need more effective treatment for these patients, and those more effective treatments are not available at primary stroke centers. They include endovascular therapy, which you all know of, and they also include research therapies. It's very possible that, and as you know, the recent studies of endovascular therapy have not been positive. We have 3 or 4 other studies ongoing. One of them is a study of ultrasound. We all know that, you probably read years ago that we did a study where we could focus ultrasound on the clot and it triples the rate of clot lysis. Well, we've now developed a hands-free helmet that eventually could be used at every primary stroke center. Every primary stroke center could put this helmet on a patient, deliver the ultrasound, and help the patient if we can show that it works. But we have to prove it first. So we have to get these patients in order to do this study. And we're doing other trials like adding antithrombotic agents to TPA or using hypothermia. Anyway, all of those things are for the most part available at comprehensive stroke centers, and where in fact research is required in order to be a comprehensive stroke center. And finally, most of these large strokes are going to require hospitalization in an intensive care unit. Most of them are going to become sleepy. Many of them are going to need to be intubated. Some of them are going to need to have a hemicraniectomy. And of course, some of them in the field, you don't know if they're a hemorrhage or an ischemic stroke. So if someone's got a very bad stroke lying in front of you, you don't know whether that's a hemorrhage or an ischemic stroke. If it's very severe, it's more likely to be a hemorrhage. And those patients are going to be transferred down to the Comprehensive Stroke Center anyway, so why not get them to the Comprehensive Stroke Center early when we can still do something about it? So those are the reasons why we need to sort of think about getting patients to comprehensive stroke centers first and trying to figure out which ones should go primarily to a comprehensive stroke center and which ones should stay in the field. Now, if I walk out of here, and I don't even know what is the closest hospital to what's the closest hospital to where I am right now? Is it Brackenridge or is it St. David's? Is it that's a primary or a comprehensive stroke center? Comprehensive. Okay. So suppose I'm out in the exurbs near one of the smaller, either I'll be ecumenical, either one of the smaller Seton or smaller St. David's hospitals that is not a comprehensive trauma center, a level 1 trauma center, and I get hit by a car, and I've got a ruptured spleen. You're not going to take me to that small community hospital. You're going to take me down to one of the level 1 trauma centers down here downtown. Now, why should it be any different for stroke than it is for trauma? We have a severity-based triage system for trauma. We need to have a severity-based triage system for stroke. So we published a paper in Stroke this past year that advocates that, and essentially it uses the Los Angeles Motor Scale, which has been validated, and it's a simple 3-item scale of face weakness, arm weakness, and grip strength that's scored 0 to 5 on that scale. And if you score 4 or 5 points, so you can imagine if the patient has a totally weak arm, it falls down rapidly and they can't move their hand, they're going to automatically get 4 points on that scale. If you have 4 points on that scale, there's over an 80% chance, and this thing is not working, but if you look at the slide, the graph at the bottom here, and this is the specificity, and this is the specificities on the left and the sensitivities on the right. So as the, oh, thank you very much. There, great. So as the number on this scale goes up on the x-axis, then the sensitivity of the scale for finding a high-grade stenosis increases. So if you have a 4 points or 5 points on this scale, there's over about a 90% chance that the patient's got a large artery occlusion, or if they have a large artery occlusion, they're going to have a 4 or 5 points. And similarly, it's very unlikely that they don't if the score is as high as 4 or 5. So basically, it's about an 80% of the patients with a score of 4 or 5. If they're having an ischemic stroke, it's going to be a large artery stroke and not a smaller stroke. So my opinion is that to some extent, we should be triaging the more severe strokes. The ones that the paramedics pick up, they do a scale like this very easily in the ambulance. Those patients should primarily go to the comprehensive stroke center as opposed to a primary stroke center, all things being equal. So we're wrestling with this now in Houston, and obviously this system has to be based for in each community, and if there's no comprehensive stroke centers, obviously it's not an issue. And so this is largely a problem in urban areas like this, but that's where most of the population lives, where we do have primary and comprehensive stroke centers. And our paramedics are asking for this. David Peirce, the director of EMS, is asking our RAC to put together a algorithm for doing this. So this is I borrowed this from our RAC, which is wrestling with this problem, and this is the Jim Grotta version of how I think this should be. I have to tell you, there's still a very healthy debate going on among the various stakeholders, and it's going to continue to go on until we reach a consensus. But right now, this is the way I think it should be, and that is, and I won't, you don't have to read all this, but essentially the top part, this is when the patient calls 911 and the dispatch person asks a few questions just to decide, is it likely to be a stroke or not? If it's not, then of course the usual dispatch occurs. But if the patient appears on basic questioning to have a stroke, then of course EMS is dispatched. If the patient has an unstable airway and the patient needs to be intubated and the paramedic can't intubate the patient, of course they'll go to the nearest emergency room. But assuming that the airway is stable, then I would advocate about 3 different criteria for whether a patient should go primarily to a comprehensive stroke center. First of all, I think actually, this is the current version, but when I transposed the slide, my little amendment came off. So right now, there's debate. What is the time? What's the proper time? Is there a time cutoff? And I would advocate that one of the criteria should be anybody within 6 hours. It doesn't make sense just to transport the delayed patients to a comprehensive stroke center. That's one of the notions out there. Well, all right, if the patient's beyond 3 hours, then okay, we can transfer those patients. But if they're within 3 hours, we need to send that patient to the nearest stroke center. Well, I would argue that that doesn't make sense. I think a better thing is to say, if the patient can get to the comprehensive stroke center within 30 minutes of where you are, then it would be reasonable to consider preferential triage. And the reason I say that is that no matter what, whether you're going to go to a primary stroke center or a comprehensive stroke center, it's probably going to take 15 minutes to get there. And if you look at the times, the door-to-needle times in comprehensive stroke centers, they're generally up to 15 minutes faster than the door-to-needle times in primary stroke centers. So if you calculate that 15 minutes to get to any stroke center, and it's maybe 15 minutes faster at a comprehensive stroke center, plus our data show that patients who go to a comprehensive stroke center are more likely to get treated even if they qualify than a primary stroke center, about a 30-minute cutoff seems reasonable. So even if you're an hour into the stroke or an hour and a half into the stroke, if you can get to the comprehensive stroke center within 30 minutes and the patient meets other criteria, I think that makes sense. So I'd say within 6 hours of stroke symptom onset, they have to be able to reach the comprehensive stroke center within 30 minutes. And then I think there are 2 essential other clinical criteria that need to be met. Obviously, if the patient has a decreasing level of consciousness and is sleepy, and you can put a Glasgow coma scale on that, or you can just say the patient is sleepy. In my opinion, that patient is somebody who's either going to have a brainstem stroke, or they're having a big stroke, or they're having a hemorrhage. They're going to wind up getting intubated and winding up going down to the comprehensive stroke center anyway. Or if they have a flaccid arm. If their arm is got no movement or barely any movement, they're going to have a 4 on the LAMS, and that patient also should go. The rest of them, they should go to the nearest stroke center as we're doing it now. So that's the way I think it should be. Right now, we're wrestling with it. I do think that at the end of the day, we are going to have to triage our patients one way or the other, and I think probably by the end, within a year, most of we'll have our system in place. We're going to look at the results of that, and of course, like anything else, you'll have to tweak it. I think one of the things we'll look at, what about, I would predict that the volumes of patients going to primary stroke centers is not going to change. In fact, it may actually go up. It's just the distribution of patients going to the comprehensive centers versus the primary centers will be more appropriately managed. So with that, I'll stop. I hope I've stimulated some thoughts. It'd be interesting to hear whether other RACs around the state are wrestling with this issue. But I'd like to hear people's comments. Thank you for listening.
Thank you. I think that's excellent and timely. So first off, the people on the dais have first choice. Do you have any questions you want to ask Dr. Grotta? So I'll start. The primary stroke centers, I'm sure they've had some interesting comments. What have the primary stroke centers around Houston said?
Darrell, you want to chip in, because to tell you the truth, people don't wear on their sleeve, I'm from a primary stroke center or from a comprehensive stroke center. I think that most of the comments have been the concern over the time. I think the initial issue was that people were concerned that if we include patients under 3 hours, that there will be some people who will be getting their TPA a little later than before. Now, nobody's a more passionate believer in early therapy than I am, but I believe if you have the 30-minute rule that they have to be able to get to a comprehensive stroke center within 30 minutes, I don't believe there'll be a substantial delay on treatment. And I think, but we can look at that as we do our data. We'll be looking at our data, and we can look back at our data this year, and then we can look once we implement this and see what is the onset to treatment times in our patients that are getting treated before and after. The other concern is a lot of comprehensive stroke centers, a lot of primary stroke centers are almost comprehensive stroke centers. They have endovascular capability, but they aren't yet qualified as comprehensive stroke centers. Can those hospitals also receive preferential triage of the severe strokes? They may have an endovascular person and an ICU, but they may not have reached all the other comprehensive stroke center qualifications. That's another bone of contention that needs discussion, and again, that can be something that's decided locally. Darrell, do you have any other comments?
Dr. Grotta has done an excellent job for many years getting us to this point. And about 4 months ago, we held a meeting with EMS medical directors and hospital stroke program medical directors. So we had input from, I think there's been 2 meetings held. I think we might have had 40 doctors in a room representing different opinions, different parts of the city. And as you can imagine, our region is huge from a mileage standpoint, and also just a hurdle of getting patients from a rural area down to a Texas Medical Center hospital creates concern. Dr. Ken Maddox, the chairman of our board, sees this as very similar to when trauma centers became designated, and we ended up in Houston with nearly all trauma centers being downtown in the Texas Medical Center, and ambulances bringing all patients to the level 1 trauma centers, and it wasn't necessarily a good thing. Not all patients needed to go to the trauma centers. So there's a desire on the part of some primary stroke centers to make sure we don't have a situation where all patients are suddenly being sent downtown to a comprehensive center. The good news is it's also, though, causing a desire on the part of primaries to become comprehensives. So we will see more facilities become comprehensive centers in our market. I believe at this point in time we have about 3 facilities that are functioning as comprehensives. The primary stroke centers in this particular meeting were concerned that too many patients were going to be leaving their market, and suddenly their volume was going to drop off, and this is kind of a market grab by the big hospitals. And we have worked hard to become a primary center, and please don't let this happen. So there was a little political worry going on in that very first meeting that I think started to subside when everyone realized, no, we need to stay focused on what's right for the patient, and that these suggestions from Dr. Grotta and other medical center physicians just made a lot of sense. I don't know if I'm touching on something you wanted to highlight further. Feel free to converse here. I think that within 6 months we're going to have something in place that will need to be reviewed again in 12 months and changed, but we're not going to do a status quo. The momentum amongst our doctors to get this going is just tremendous, and it's going to lead to other topics as well, not necessarily stroke. Nice achievement. questions?
So, Dr. Grata, we're obviously having the same problem here in Austin, and we go back and forth, and we meet with the medical directors and the stroke medical directors on a regular basis. But I actually have two questions. So the first question is the 30-minute time window. Is that a geographic window, or is that? Did you come up with that from?
Actually, well, in trauma, when I asked Dr. Persis, initially in the publication I wrote, I said 40 minutes. And I said, why? And that came up because he said that in the city of Houston, they feel that all the trauma, level 1 trauma, can get to a level 1 trauma center from all parts of Houston within 40 minutes. So I said, well, if they're taking level 1 trauma and waiting 40 minutes to get down to the level 1 trauma center, then it makes sense to have 40 minutes for stroke. But I shortened it to 30 minutes because, well, first of all, that was sort of the general feeling of the group, but also because I just sort of did this calculation. We looked at how long it takes, and we know how long it takes you're on scene for a paramedic. Generally, it's about 15 minutes from the time they depart the scene to the time they get to the primary stroke center maximum. And there is about a 15-minute difference, 10 to 15-minute difference in the door-to-needle time between average door-to-needle time between primary stroke centers and comprehensive stroke centers. So you put those two together, it's about 30 minutes. So I figured you can't argue that it's going to delay treatment then if you keep it to 30 minutes.
And is that a national average, or is that your RAC's average?
The
Primary stroke centers.
The door to the scene to time was a calculation we made years ago in a publication in Houston, and the door to needle time is also at least data I've seen from our RAC. But I bet you that it'll be pretty similar when you look at the Get With the Guidelines data. I don't know if it's been published yet in the Get With the Guidelines.
I have one more question.
But it doesn't. But you know, it doesn't really make sense to not take the early patients to a comprehensive stroke center, because I mean some of them, the appropriate ones. I mean, even if it's a 5-minute delay, I mean, we're not talking about huge delays if you institute the 30-minute rule. Because these are, if they have a large artery stroke, it's just not likely they're going to respond to IV TPA. So that 5 minutes you may mortgage away by getting them to the comprehensive stroke center. And we don't know this, but my guess is that those patients will benefit from the added options that are available at a comprehensive stroke center for treatment that are not available, whether it's endovascular therapy or research protocols or whatever.
So can you weigh on the scenario of say a patient having a stroke, a small vessel stroke, or a mild infarct around the corner from a primary stroke center, say maybe a mile away. Here in our setup, it's also 30 minutes, 15-minute delay. And so that patient would be transported from maybe the PSC in site all the way down to the comprehensive. So maybe
no, if they had a mild stroke, they'd go to the primary stroke center.
So we go to the highest level of care.
Well, so I would argue that maybe that should change. You know, if the patient has a 4, less than a 4, and there's a primary stroke center that's closer, they should go there.
So you could put the severity adjusted within that 6-hour window. Yeah,
I think it should be severity and not just driven by time. I mean, I think it should be the fastest that you can get the patient treated, and if the patient has a small, and that's why I'm saying I think that the primary stroke centers may actually see an increase in the number of patients they take care of as a result of a system like this.
We're focusing now on the education of the community. This is going to progress. The embarrassing thing is the number of people that delay coming for care. And so we are going to be doing some benchmarking, and then we're going to be doing some teaching and some education, and with the help of Genentech, we're going to be doing some high-level advertising in order to see if we can get more people to come for care sooner when they have an onset of symptoms. That's where everyone's focus probably needs to be. It's kind of surprising the low number of ischemic strokes that are getting care within the time frame that they should.
Homer, you have a question?
I'm from a rural area. The numbers that you guys speak of is what our doctors end up getting in their, they read the material and the research and so forth. Our closest facility that could possibly offer any additional care for stroke is 45 minutes by ground, and by helicopter it's not a whole lot faster. To go to a higher level of care, which would for us be Lubbock, it's an hour and 45 minutes by ground or 45 to 50 by air. Our docs read this information and they say, oh, it says 30 minutes, we can't meet that, so bring them here. What happens is they stay for 2 hours getting CTs, getting the CTs read because we don't have radiologists, getting the labs run, that kind of stuff, and it's 2 hours before we even, can get them out. And then it's another, if we're fortunate enough to be able to fly them, it's another 30 minutes to 45 minutes to the place, or if we ground them, which we do a lot, it's a long time. And is there a way that through your research you could address or mention possibly folks out in the rural areas that just don't have, we're kind of out there by ourselves, and the guidelines we're reading are what they do for a city, and it doesn't fit us, and it's not helping us.
Well, yeah, obviously that's the case when you're talking about 30 minutes, and I appreciate those comments. So there are several different responses to that. I think the most important one is that any system that's put into place has to be regional, right? So it has to take into consideration what are the realities of your distribution of hospitals and how long it takes to get to them. Houston's a weird city in many, many ways. Not as weird as Austin, right? Keep Austin weirder than any place else. But it's still weird in that all of the comprehensive stroke centers are within a block of one another. As Darryl said, that may change. But there are other cities where there may be a better distribution of comprehensive stroke centers where you might have a different time arrangement. Now, in your situation, really the crux of the issue is when a paramedic arrives on the scene, are you going to, I guess what you're asking is, should you fly that patient to Lubbock or bother to take them to your local hospitals who's really not going to do anything? And I think that has to be a regional decision. Your time frames aren't going to be 30 minutes. Maybe you should have, it should be based, again, not on the time, but on the clinical status of the patient. If the patient got a large stroke, they're going to be an obvious stroke, they're going to be shipped anyway, and they're within a reasonable time frame for treatment, maybe they should go directly to the larger center. I just think it has to be regionalized. And then the other thing I would argue, or I would point out, is the proliferation of telemedicine, which has been a huge thing in this state. We've been part of. I have to mention that Dr. Rutledge mentioned the allocation from the state legislature. $4.5 million of that allocation was to establish a telemedicine network in the state. You may not know this, but the chairpersons now of each and every medical school in this state, not just the UT schools, but are stroke specialists. And the vice chancellor for research at the UT system is a stroke specialist. And so we're taking advantage of that expertise, and we formed something called the Lone Star Stroke Consortium. And the idea is to have a hub and spoke statewide telemedicine program to identify 20 sites outside of academic centers that are not comprehensive stroke centers. These are primary stroke centers or centers that want to be primary stroke centers, but where there's enough volume that we could carry out research, clinical research, and put patients into our clinical trials remotely at those sites. And that network is a reality now and will be established. We've already enrolled one patient at a hospital in Beaumont into one of that ultrasound enhanced clot lysis trial remotely by telemedicine. So this is a reality that's going to ramp up over the next year or two. So, and then of course there's all these other telemedicine networks. Each and every one of these major sites are going to be developing, and telemedicine, I'm sure you know, is a very powerful tool for extending stroke care into rural areas. So I guess those are the two responses I'd have, but I think it just has to be regionally designed, and you're right, this is a much more of a urban oriented type arrangement.
We as a RAC are going to push the comprehensive centers to have partnership agreements in place with all hospitals we identify that are not primary stroke centers, as well as those that are, so that there is a speedy ability to transfer into the comprehensive. So maybe next year we'll be up here talking about that. But we do see some hospitals that have aligned with rural hospitals, and the service can be quite fast. And I would just try to avoid the 30-minute thought in your case. It's a fact. Meanwhile, the patient still deserves priority.
Yeah,
One comment. Excellent presentation. I'm with Covenant Health. We're the recipient of most of Homer's patients. We do have the comprehensive abilities, although we're not 24/7, obviously. Not looking at the comprehensive certification just yet. A couple things come to mind with your presentation. One is the level 3 support center. That is so important in the rural area. And for you folks that didn't have the privilege of having a primary stroke center on every corner, such as in the Houston area, the level 3 support centers is how to get rapid TPA infused for all those patients that qualify, and not necessarily just the ones that are requiring transport to the comprehensive capable facilities. The second thing is, as a paramedic, that gives me heartburn about not getting my patient to the closest facility that can treat them. So I think one of the biggest challenges, I don't know how Houston paramedics think, would be, why am I not taking my patient to the closest facility? So I think education is going to be a big thing on the paramedic end of it. Is we've drilled into our paramedics head 24/7. You take that patient to the closest facility that can adequately treat that patient.
And the answer is that you're not treating them when you treat them with TPA if they're having a severe stroke, or you're treating a very small proportion of them. So it's like saying, and it's in that can treat them, and it's just like taking a severe trauma, someone with a ruptured spleen, going to some place that doesn't have a surgeon on call, right? I mean, that hospital can't treat them. The disease they have is not treatable, and so we have to stop thinking about all strokes are the same with TPA. Now this gets philosophical, but when I was involved in the NINDS trial in designing the protocol. When we designed the protocol, at that time we had no idea, who was going to respond, and we put all comers into that trial. And so I'm not here to say that we should not treat patients with large artery strokes with TPA. They do respond. Some do respond, and it's better than nothing. But it doesn't work adequately. And if we don't get those patients to a comprehensive stroke center, we are never going to have better treatment than TPA. And so if we're going to move forward and be able to provide better care for these more severe patients, then we have to have a system that enables us to develop those new treatments.
Again, referring to the education of the paramedics, they got to be adequately be able to identify those large vessel occlusions before they make that transport decision.
And it's got to be a fairly straightforward, simple algorithm for doing it.
Other comments?
Yeah, actually.
Yep, go ahead.
Actually, I was going to ask a similar question on the education. Actually, what I was curious about was one cluster of questions. So, when you're doing that with Houston, do you have the percentage of over and under triage, just like in trauma? We have some issues with, you fly because the car flipped and the mechanism you send them. Was there an issue with over and under triage coming to you from EMS? And with that, you're using the LAMs, and we've had an issue in Texas where we mandated at one point that we do the Cincinnati pre-hospital screen. We've gone to saying, okay, do a reliable, which is LA or whatever. Now we're talking LAMs. So my concern is on confusion within the education for EMS and the iterative reliability of LAMs compared to the Cincinnati and LA as well, based on that. And then also your spreadsheet, paramedic input, that would kill me at night. So is there that 3 a.m. pocket card that says, if X, do Y.
Well, so I'll answer maybe in reverse order. That's just sort of our construct of how to do this, and but there's obviously a check sheet that we're developing for the paramedics to use. As far as the LAMS is concerned, the LAMS is a component of every scale, essentially. I mean, in reality, there's really very little difference between the Cincinnati scale and the Los Angeles scale, all these scales. We even have our own. We initially developed something called the Houston Paramedic Stroke Scale, which is not too much different. They all are quantitate the motor strength. And I don't really believe that it would be all that confusing to build the LAMS into whatever scale is being used locally. It obviously is easier to build it into some unit that's using the Los Angeles the LAPS because it's a subsection of it, but I really don't think it'd be a problem. As far as we have not implemented this yet. We are designing it, so we don't know the answer to your question, but about whether there's going to be under triage or over triage. That's exactly one of the things we need to see. What happens to our our onset to treatment times with this new system? Are we efficiently allocating patients to the right hospitals compared to what it is now? Those are things we have to look at. I can tell you, in our own hospital, there is there's anything in under triage of severe patients. Most of the severe patients that we are getting right now are transferred to us, and it's frustrating because the IMS, and again, now I'm getting a little bit of feel, but if you look at the endovascular data from the IMS trial, which was a neutral trial, didn't show any benefit of this is the study that was recently published, where patients got IV TPA and then endovascular therapy was added on, and there was no benefit. But if you look within that trial, the patients who got their arteries open by 4 hours benefited. And so there's no reason to think that it's any different with IV TPA or endovascular therapy. You can't negotiate with the brain how long it's going to hold its breath. It's one of my favorite sayings. It's going to die whether you get that artery open by TPA or whether you get it open with a catheter. No matter how you get it open, you only have a certain amount of time to get it open. And patient after patient goes to a primary stroke center, gets IV TPA, they say, oh, we've got this big stroke, let's transfer them down, and by the time we get them to be able to do endovascular therapy, we're 6, 7, 8 hours, and that doesn't work. It doesn't work, or if it works, it's a very rare patient that really benefits at that late date. If we're really going to have a benefit from endovascular therapy, we got to see those patients initially right away in order to be able to get the artery open within 4 hours or at the most 5 hours. So, I think there's right now a gross under triage of severe patients initially to comprehensive stroke centers.
We are going to begin tracking transfers from the 27 or so primary stroke centers to the comprehensives, and that will be reported through our stroke committee and be data that we use to compare and contrast facilities.
I have a quick question. What is your door to needle time in your hospital? You said, because I know many primary stroke centers, you're trying to get under 60 minutes.
Yeah. Our average door to needle time is 50 minutes.
50?
50, 50. And nationally, as you know, it's over 60 minutes average. And the goal is 60. But if you honestly, accurately chart your door to needle times, they're much longer than most people think they are. And, obviously we get many patients faster, but the average is 51 minutes the last few months. So it goes up and down a little bit. Sometimes it's in the high 40s, sometimes it's in the mid 50s.
Yeah, but if I guess just being a gadfly, if a primary stroke center is doing door to needle in 50 minutes, also that 15 minutes that you talked about isn't there.
Right.
The other question I have is...
And you don't, and the paramedic, there's no door to needle time in lights outside the ER door, right? So the paramedic doesn't know that if I take them to this primary stroke center, they're going to get treated in 40 minutes as opposed to as opposed to 70 minutes at the other. They generally have an idea. I can just tell you what the data have been, and there is a difference in average door-to-needle time between primary and comprehensive stroke centers. And that's not to say that a primary stroke center can't do it quickly and just as quickly. They certainly can. There's nothing, if anything, it's difficult. I personally believe now I'm really going to go out on a limb, but I personally believe that 10 years from now, we're not even going to be treating patients in the emergency room with TPA. We're going to be doing it in the ambulance with mobile stroke units, because it's ridiculous that we have to wait until patients get to the emergency room and go through this whole rigmarole, no matter what we do in our emergency room. And we have 2 CT scanners, we have a fellow who lives in the emergency room, and there's still a whole process that has to take place when patients get in the emergency room. And we need to get rid of that. We need to get rid of that. And we can with new technology. So that's where I think the field really is going. This whole argument is going to be moot. Well, it will still exist for treatment beyond TPA, but for treatment with TPA, I believe the argument will be moot, at least in urban centers, probably 10 years from now.
Another question that comes to my mind is, let's take an example of some research, say hypothermia for large strokes, which you and I are both advocates of. If it works for large strokes, do you have thoughts that it might not work for small strokes, like a small lacunar stroke, where it may only be a stroke scale of 2, but someone's looking at a monoplegia, which is going to destroy their career?
Right. So,
I think the point bears on
yeah.
using the level of
right. Whether it's hypothermia or not. I mean, we're doing trials in minor strokes. I mean, one of a real question still exists out there is whether the very minor strokes benefit from TPA. So there are randomized trials that are getting started for patients who have minor strokes, and to see whether they benefit from TPA, or should they be treated with ticagrelor or some other of the newer antiplatelet drugs. So it's not just the severe strokes that are good research candidates, whether it's hypothermia or one of these other protocols might work for, but at least for TPA and for that initial treatment, it makes sense to triage on the basis of severity, but it may be that each community would be different. I mean, and this is where, I know I do feel a little bit like a voice crying in the wilderness, because all of this is very market driven. And so, as Darrell pointed out, as soon as we started arguing or discussing about triage, everyone's interested in their market share. But in reality, Houston's a unique environment. We do a lot of clinical research. So it seems to me, as a community, if we want to consider ourselves a community that's advanced in terms of doing research, and we're proud of the Texas Medical Center and all of the research that it does. Well, if that's the case, then we need to support the research in our community, and the hospitals all need to participate. If there are research trials going on that patients may qualify for, I think it's in everybody's best interest, including the patients, in my own bias as a clinical researcher, that patients go to where those trials are run, and that we in the medical center do our best to have those trials available out in the community as well, which I think we can do through this telemedicine network. So I believe that the research component of all of this and finding better therapies, whether it's a minor stroke or a major stroke, could be built into the triage mechanism in those communities where there is a lot of research going on. Now, that could be confusing to the paramedics. We're not going to tell them, well, we need to go through the inclusion-exclusion criteria for each trial, but at a particular time, you've got certain trials going on at the medical center, whether it's at our institution or another one. Maybe the criteria during that time would be different. I can tell you that, the TPA trial back in '90, when we did it, would never have been possible if EMS didn't work with us. EMS, I went to Paul Pepe at the time, who was the director of EMS in Houston, and I said, Paul, we're about to start this trial with TPA. Can you call me anytime you pick up a patient with a stroke? At that time, there was no notion that any stroke patient would ever be identified early by EMS, and they did. So you know, I don't think the problem is with the paramedics and with EMS. In fact, whenever I've gone and talked to EMS agencies about research and given them the opportunity to participate and get engaged in them, they've been very enthusiastic. If there's a resistance to this, it's on the part of the hospitals and driven by their concern about market share.
I have one small admonition in regards to research. We do not advertise research. We may educate, but do not advertise. That's going to get you into a lot of legal problems. One of the things I think so unique about Texas is we have so many different environments, and it's why all this is RAC-centric and RAC-driven. And what I'd like to do is suggest that we form a subcommittee to review and make recommendations of the bypass criteria that we have, and then also with the SurveyMonkey to see what everyone's doing right now. And we can, you know, a focus of this committee can be an education and a clearinghouse for ideas. And I would congratulate Houston on being innovative in that respect, and I look forward to see what's going to happen. But Dr. Cravens, would you like to head that subcommittee? And anyone else want to be on it? Warren, yeah, and Lisa. Okay. So we'll do that subcommittee. And so that's the end of Dr. Grotta's presentation. And so now we're out now to general public comments. Are there any comments? Please come forward.
My name is Jacob. I'm from the HCA North Texas Division. I'd like to answer a couple of your questions, Warren. In 2008, we started doing this very same thing. I congratulate you on doing that. One of the things, the big difference between the Cincinnati and the LA and this scale is a severity, a disability scale, able to be used for triage, whereas the LA and the Cincinnati are merely looking for the presence of stroke. And that wasn't something that we could use for triage very well because it was just looking for the presence. So we started developing a new scale in 2008. After a couple of years of trials, we came up with what we're now calling the Rapid NIH score. And what's good about it is it mimics the full NIH up to a score of 27. We figured out after about 25, 26 in the acute setting, we ended up intubating them anyway. So it didn't really matter what the score was beyond that. But we started doing that. And so for the triage, over and under triage, before the scale, it was being over triaged. EMS was bypassing all the primaries and coming to our comprehensives. And so we would end up with a bunch of TIAs and primary strokes on our floor, could not transfer in the comprehensive patients due to capacity. So we did a lot of outreach education, rolled this scale out among others, and tried to really get EMS to triage appropriately. And when we did that and partnered with the primary stroke centers in the rural areas saying, hey, if you get this patient, you give TPA and 30 minutes later they haven't decreased their NIH by 3, do these things and call us. And we use telemedicine and most of the time it's just over the phone and looking at images to determine whether or not this is an appropriate candidate for comprehensive. That way, if they're not a candidate, we can leave them there. There's no need for the transfer. And then as soon as we do our comprehensive, we send them back to that facility for their follow-up, their rehab as quickly as possible that we can get them back into that facility. That has helped us with our triage and our capacity issues. That way we don't have a neuro floor full of TIAs and we're able to get in those comprehensive patients.
That was great. Any other public comments? No? Are there any announcements? Oh, please, go ahead.
I just wanted to share that on August 1st, the Southwest affiliate of the American Heart Association Advisory Committee had a webinar that we actually put together a resource guide, mostly for patient education. There also is information for community education and even professional education. And it is available online. So I wanted to share the website with you. Actually, the webinar is there so that you can listen to it. The slides are there so that you can hear or see it. And then also the resource guide is available for you to download and use as, you know, however you desire to use it. And the website is www.heart.org /SWA quality. So, pardon?
Say it again, please.
Okay, www.heart.org /SWA quality. And there's a lot of good information that can be tailored to whatever your program needs. So.
Just send that to me, I'll post it to the minutes.
Okay.
Are there any other public announcements? One is I'm going to change, it's a work group, we're going to make this a work group, not a subcommittee for technical reasons. Any other public announcements?
Dr. Rutledge,
Yes,
would
ma'am.
you like to say something about Dr. Swatner's or Senator Swatner's issue?
Oh,
Or would you like me to?
You can if you want. What I was going to do, well, now that it's up, I think we have to say something. Please go. So please go ahead and tell the story.
Senator Swatner, I believe I'm saying that correctly, had some questions related to the care that's delivered at a primary stroke center. He was concerned, he expressed concerns to the department that a primary stroke center does not have to have a neurologist immediately available to see the patient. We've talked to the senator and basically told him that our designation program is based on the national standards for Brain Attack Coalition, and tried to explain to him some of the nuances between the primary and the comprehensive stroke centers. We have responded to him as such that this is the way our designation programs are set up, but we've also said that we are in the process of reviewing 157, the entire chapter, and that we would put this up for discussion. Is this something that Texas needs to address further in rule? So I just wanted to let everyone know about that.
And so that's something that I think can also be addressed in the triage of the work group that we just formed.
Okay.
Because as such, we can't change the Brain Attack Coalition's recommendations or the criteria for those or the statute that affects them. But it could be looked at a work group level. I guess my concern would be there are many people who take care of strokes, not just neurologists. There are internists, ER physicians, neurosurgeons, neurointerventionists, and so there are far-reaching ramifications of that can't address just right here, right now. So we'll add that to your work group for a recommendation.
So noted.
Yeah. Are there other public comments, announcements? If not, let's adjourn. Thank you, everybody. Thank you very much.